let me know. So good morning, everyone, and welcome to our third recovery-friendly workplace resource session number 3. Today, we will be hearing from Aware Recovery Center, Granite Recovery Centers, Farnum, and Dismas. I will actually be presenting on Dismas today as Cheryl Andrews, the executive, will not be able to join us today due to illness. So I'll be sharing that first. And then Adam, I will ask you to go next. Adam Carey is the Regional Clinical Outreach Manager for New Hampshire and Maine for Aware Recovery Center. And Spencer Bush-Brown, the Vice President of Business Development, is going to be here with Granite Recovery Centers. And last but not least, we'll have Alexandra Hamill, MLADAC and Director of Clinical Compliance, and Charlotte Trenholm, Vice President of Clinical Services from Farnum, will wrap up this morning's presentations. So with that, it looks like everyone is muted. I will ask that everyone stay muted when folks are presenting. We will hold verbal questions until the end, but you can certainly put questions in chat because we have a team here that will be watching for those questions and will alert me if I happen to miss anything. My name is Karen Morton Clark, and I am going to be facilitating this session today. I am a recovery advisor for the Governor's Recovery Friendly Workplace Initiative, which is also an initiative that is managed and administered by Granite United Way, our great partners there. And I am very happy to see so many of you here today. And one of the goals of today's session is not only to learn more about the services that each one of these providers does provide and offer, but also for anyone online that has a family member, a friend, a loved one, or a colleague. We want to make sure that you're hearing what you need to hear to know how to perhaps partner with your friend or your loved one to connect them to potential treatment resources as needed. So with that, I will go ahead and get started. And again, I am just going to read you some information about Dismas Home of New Hampshire. And again, Cheryl regrets that she can't be here today, but to give some information, Dismas Home of New Hampshire is a state licensed 90-day low-intensity residential alcohol and drug rehabilitation treatment and reentry program for previously incarcerated women. Dismas Home offers residential rehabilitation services and is conveniently located in a quiet neighborhood on the west side of Manchester in New Hampshire. The location is a half a mile from downtown Manchester, close to employment opportunities, community services, and self-help recovery support groups. Comprehensive support services are available to residents during their entire stay. Residents are actively involved in planning and initiating transition back to the community at large. The transitional program is designed to support residents through education, training, therapy, and recovery services. In addition, the Dismas Home program staff assist residents in the search for housing, employment, and offer the opportunity to learn life skills in preparation for their re-entry into the community. Once a resident has made the transition back into the community, Dismas Home offers wraparound services to continue the support needed to reestablish strong, positive connections that will empower long-term success. Eligibility to become a resident is as follows. Be incarcerated in New Hampshire within 1 year of applying. Be a resident of New Hampshire. Be 18 years old or older. Not be convicted of arson, sex offense, assault, or violent crime. No violent behavior while incarcerated. Income falls 400% below the federal poverty level. Being treated with approved medication-assisted treatment for addiction. And a thorough case review by Dismas Home clinical staff, including a one-to-one interview. In terms of pregnancy, pregnant women may apply to Dismas Home. However, new applicants and current residents who are pregnant will not be allowed to remain at Dismas Home following childbirth unless arrangements have been made for placement of the child. I will include those notes as well as I was provided by, Cheryl provided an annual report to me as well. And I will include those documents in the follow-up email that we will send likely tomorrow following this presentation. So with that, I will ask, since this is sort of a separate presentation and I do not represent Dismas Home, but I hope I'm doing them justice. Does anyone have any questions that I could pass along to Cheryl about what I just shared? Okay, so seeing none, what we'd like to do now is continue and have Adam Carey present about services at Aware Recovery Center. And I will go ahead and put the website for Dismas Home in the chat right now. So Adam, the floor is yours.
Good. Thank you so much, Karen. Good morning, everyone. I see some, well, not a lot of faces, but some familiar names. So some people I know and some new ones. It's a pleasure to be here this morning. Again, as Karen said, my name is Adam Carey. My title is Regional Clinical Outreach Manager. So I represent Aware Recovery Care in the states of Maine and New Hampshire. It's my job essentially to build relationships, grow relationships, and just make connections with other organizations impacting the SUD community on behalf of Aware Recovery Care. So it's a pleasure to be here this morning. I want to thank the Recovery Friendly Workplace team for all the hard work they're doing just to increase awareness and change the conversation around SUD, especially in the workplace. I was having a conversation yesterday with the CEO at Journey Magazine, a publication in Maine, just about our mutual belief that one of the places we could really kind of preempt that, really kind of low bottom place, or really just get to people that might be suffering from SUD early, is by getting them in the workplace kind of before it's gotten to that state of, really high consequence for use. So Aware Recovery Care started back in Connecticut in 2011. Today, we've grown to 14 agencies in 10 states, serving about 2,700 people across the country. We do have states 11 and 12 coming online very quickly here, one down in Georgia, another in the Westchester, New York area. So we've experienced quite a bit of growth, especially in recent years. Aware Recovery Care was founded on the idea of giving people access to treatment who maybe could not access inpatient or was not acute enough to warrant an inpatient level of care, and just really provide, what we feel is a really comprehensive approach to address, stressors and triggers and really affect long-term positive clinical outcomes by delivering care right into the home. So our kind of claim to fame is that we are sending people live in person right into the home to sit down in the living room, the kitchen, or in the community of our clients. The recovery teams consist of 4 people. So each client coming in gets these same 4 people. 2 people are what we call certified recovery advisors, or CRAs. These are people that we hire for in care, and I'm admitting people to the waiting room as I'm talking here. So just so you know, there are people still coming in.
Adam, we'll do that. No worries. Thank you.
Okay. Yeah. Take my co-host responsibility seriously here. So so for Aware, everyone's getting these 2 certified recovery advisors. So these are people that we hire for recovery capital and fit, and then we vet and certify them internally to become what we call IHAP practitioners. So IHAP being our model of care, in-home addiction treatment. There's a lot of acronyms, so bear with me on those. And the idea is that we really want the care to be delivered peer-to-peer. So it's not about, a clinician going into the home to deliver clinical care every single time. It's about having a peer go in with lived recovery experience to deliver and administer a clinically informed curriculum of care that we've built out. So just to speak on that curriculum a little bit, it is biopsychosocial. So it's been influenced by a few different therapeutic modalities, those being cognitive behavioral, dialectical behavioral, and occupational therapy. Again, this curriculum is not a replacement for those therapies, but more that it's been informed by those so that we can have peers going in to deliver clinically informed care. The curriculum is pretty cool. There's a couple things we can do. We can go through it in a lateral fashion. So week 1, lesson 1, week 1, lesson 2, and so on. But really what I love is that we're able to pull specific interventions out a la carte to address stressors and triggers and circumstances as they're coming up in real time. So we can use these modules and lessons that we built out to really address things as they're happening. So, if somebody's going through an ongoing difficult situation at work or with the family, or just some type of stressor or barrier that has to do with reassimilating into the community, we're able to kind of pivot on a dime, pull an intervention out, address that specifically, and then use this long-term treatment plan to follow up and, double down on that intervention if necessary, say, hey, how is this going? So we actually have a 52-week treatment plan. So our program does go up to 52 weeks. That's what insurance will cover. Somebody doesn't have to stay with us that long, but that's how long, we'll be there for them. Just because we feel that that long-term care plan is the best for, affecting long-term change and good outcomes. So we'll use that treatment plan and literally adjust it to meet the client as the client's changing, as they're starting to become stronger in their own recovery. We can kind of adjust that as we go to really stay with them and meet them where they need to be met. And it gives us the chance to really circle back on these interventions. So the result is that we're able to work with people in a hands-on way and help them learn by doing in real time, experientially, versus, people that go to inpatient care only, as opposed to doing inpatient care and then a program like ours, where we're really able to build on that foundation that they've done in inpatient, where they were, focused more on just kind of stopping the addictive cycle and learning in a more academic way some of the skill sets that they'll need. We're able to take that, follow up on that, and help teach them in real time, support them around their schedule, in their home, in their community, day in, day out, to help them learn the skills that they're going to need by doing that in real time. So that's really what the CRAs are doing, the Certified Recovery Advisors. They're really the lifeblood of our program. They're the ones forming the primary relationships with the client. In addition to those two people, on every team, there is what we call a care coordinator. This person is a nurse, so generally an RN or LPN. In some states, you may also see a master's level social worker in this role. And the idea really is not only to administer some clinical assessments and support the client, but also to work in the background to collaborate amongst any outside providers the client may have. For example, a PCP, long-term outpatient mental health professional, psychiatric med management professional, medicated assisted therapy professional. If there are ongoing legal difficulties, a probation officer, parole officer, DCYF representative, or even ongoing divorce proceedings, this care coordinator is really making each of those individuals an extended part of the treatment team to get everybody pulling in the same direction for the client. And so in this way, we really have, what we believe to be a truly individualized wraparound care program, because we're able to really work outside with the client and take into account all these different individuals and all these factors in a client's life. In addition to that care coordinator and those two CRAs, the fourth team member, we call a family education facilitator. So in my opinion, working with the client and addressing the client is maybe 50-60% of the whole picture, because if we don't change the sociocultural environment, if we're not producing any change in the environment or in the major family system, ultimately, as I'm sure we all know on here, it becomes so easy for people to kind of just drift back into the same behaviors, the same patterns, the same people. So what we do is we dedicate a professional to the family for the entire year of care. That person is available for the full 12 months by phone to support. They're also available we have 10 sessions that we do with family members. So these are virtual, they are psychoeducational, and it's a curriculum that we built out to help reduce stigma and improve education in the family system. So a lot of people, as I'm sure we've all seen, unless you've been through addiction yourself, it's very hard, or even sometimes, even if you have, it's very hard to keep that family member in a mental place of like, this is a sick person, this is a brain disorder. I need to understand that this will be a long-term rehabilitation process from a long-term illness. And instead, it's all too easy to slip into this place where, we're taking it personally. And, we feel that in educating the family members is really, the value of that can't be overstated. And so we do that, and we offer the family a support person. So we hope by this two-pronged approach, addressing the client in real time around their schedule, in their home, in person, and also helping to change that family system or that sociocultural environment into one that's going to be of maximum benefit for the client. When we do these two things simultaneously, we really create a foundation for the client that hopefully they'll be able to stand strong on moving into recovery. So if you multiply this out by 12 months, what you have is a real opportunity here for people to change the way that they think, to change the way that they behave, and to really just get the support they need long-term. We do offer a few additional things. Right now, we can bridge psychiatric prescriptions for people coming out of inpatient care until we find them a provider in the community. We do what we call bad time to forget. It's psychotherapy, internal psychotherapy that we have. So we have therapists now that work for us. So licensed clinicians in the community, LADACs, MLADACs, LCMHCs, and we have 20 sessions of SUD focused mental health care that start on week 1 and that come with every single person coming in. So this might be just a Band-Aid, but we find a long-term, more permanent provider in the community, or this may be, you know, all that the client is willing to do, but we just wanted to make sure there was something there to address mental health concerns. In addition to that, we have what we call our in-home withdrawal management. So we have a limited actual medical detox that we can perform in the home for people. So we have an RN who supervises this team. It's a specialized team that works within each given territory. And as long as there are a few caveats to make sure that it's safe and it's ethical. So bearing those in mind, as long as the person is appropriate for this, we can come right into the home. That RN will be in the home multiple times a day, and we can safely do a full medical detox for somebody from a alcohol use disorder, benzo use disorder, or opioid use disorder. And then lastly, we do have limited MAT right now. We're currently prescribing naltrexone and inducting onto Vivitrol. And again, within a certain catchment area, we can actually come into the home to administer the Vivitrol shot ourselves for people. So these are just some of the things that we built out to try to make this a truly comprehensive program and to just give people access to care, even though they might need to keep working full time, right? That's one of our claims to fame is we can keep people engaged in the workforce. They can still receive quality treatment around their schedule while supporting their family. That's something we like to do. So I'm sure I'm going to remember something I forgot in about 5 minutes after I get off here, but I'd love to answer any questions, and I put my contact info in the chat. I just want to stress to everybody, if you're willing to just throw my phone number, either my cell or my work mobile, they're both in there. Just throw that in your phone so that I can be a contact. If you have somebody you think is a good fit, if you have any questions at all, I'm happy just to answer those questions. I'm a person in long-term recovery. I've also got an admissions and background, or background in admissions. So I'm always happy to just client face to answer those questions. I won't be a car salesman. Whatever I can do to help, I'm honestly happy to do that, including getting people linked to other programs that are not Aware Recovery Care if Aware is not the right fit. So please feel free to use me as a resource and contact me anytime. Lastly, we're in network with Anthem Blue Cross Blue Shield and Tufts right now in New Hampshire. We're hoping to bring Aetna on board soon. We're having conversations about Harvard Pilgrim. There's focus on Medicaid up at the top levels, but we're not there with those yet. So right now, it's really primarily going to be if you run into an Anthem policy or a Blue Cross Blue Shield policy, or if you happen to have somebody with Tufts, maybe come up from Massachusetts or that's up from Mass, please think of us. It's often very, very affordable because Anthem really appreciates what we do for folks. And that's it out of me. I'm happy to answer any questions. And again, feel free to contact me anytime.
Adam, thank you so much. That was a great overview. And you just added the one question I was going to have, which was about insurance. So I appreciate you doing that. And the hope would be that at some point you will be able to serve Medicaid clients. I can only say, this is just me personally talking from a prior role that I held in which I was working directly with clients, and Aware was a wonderful, wonderful program for some of my clients that really had lost all hope and really gained ground and moved forward on the Aware Recovery Program. So I just wanted to add that. And then a question I would have, and then I want to open it up to questions from the group. Do you offer any kind of a self-pay program for those that, don't maybe have some of the insurances that you mentioned?
Sure. So our self-pay right now, it's just a flat rate of $4,340 a month. So $4,340 a month. Don't ask me why that extra 40 is on there, why it's so specific. I'm not sure, but that's a self-pay rate per month. And while that can certainly be steep, the way that I look at that is, the $15,000 that somebody would pay for 30 days out of pocket at an inpatient rehabilitation facility, that same $15,000 would buy 3.5 months of everything that I just mentioned with Aware Recovery Care. So on a scale of how much it costs to self-pay for any level of care, it's actually pretty affordable given what we offer. So yeah, so $4,340 per month is the self-pay. That's definitely an option.
That's awesome. Thank you, Adam. And so I will just open it up to questions from the group at this point. And if there are questions that you want to hold because you want them to be confidential, we will turn the recording off towards the end of this presentation. So I'll open it up to the floor. So seeing none in chat or anything, anyone's raising their hands. I don't see anyone raising their hands. I am seeing that Charlotte Trenholm is on now. Charlotte, would you be able to begin the presentation for Farnum by chance?
Oh, we're actually waiting for the rest of our team to join us.
Okay, all right. I wasn't sure. I saw you
Yep.
on, and what I'm noticing is that I don't see Granite Recovery Center on. I have in this time emailed them, and we've emailed them the Zoom link again, and we're not sure why they're not here. But of course, we'll welcome them if they do arrive a little bit late. So in the interim, I've actually pulled up the website for Granite Recovery Centers. If one of the team could put graniterecoverycenters.com into the chat, that would be helpful. And also the admissions number for Granite Recovery Centers is 855-620-1440. And then I'm just going to give a little bit about their mission and vision statement with the hopes that our point of contact, Spencer, will be able to join us and share in more detail. But their mission statement is to transform lives by setting a higher standard for accessible client-centered treatment through their commitment to innovation, accountability, and compassionate care to facilitate positive, lasting change. The vision is to lead the industry by providing the highest quality addiction and mental health treatment services. They list their values as integrity, respect, innovation, excellence, and teamwork. I'm going to, I gave you the admissions number. And I want to note that on the same website, and I'm at the top on the toolbar, I guess I could share my screen, but I'm hoping that Spencer will be arriving soon. You can contact an admissions professional via this particular part of the website. And what they'd be asking for is that you provide your first and last name, your phone number, and your email, and then you just click "You're Not a Robot" and you submit. And that way somebody can get back to you if that is the preferred way that you would prefer to go, as opposed to the phone call. I wanted to give you an idea of the locations. There are several. There's Green Mountain Treatment Center, which is in Effingham. There's Liberty Bay Recovery Center, which is, I'm looking for where, because that's a new one to me. Thank you, Adam. And then also there's Canterbury, Salem, Granite House, and a variety of options for sober living, including Berkeley Sober Living, Harmony House, Freedom House, Queen City Sober Living, which of course is in Manchester, and Vision House Sober Living. And then what they treat, I want to just go a little bit into that. And team, if you can let me know if Spencer does jump in, that would be awesome. Let's see. So in the realm of alcohol use disorder, they talk a little bit about that. Alcohol rehab is a term that refers to programs that help a person abstain and oftentimes detox from alcohol. Candidates for alcohol rehab have what is referred to as alcohol use disorder, or AUD, which means that the person cannot stop drinking and often drinks much more than they should. Here we discuss what alcohol rehab is, how it works, and how it serves the person with AUD. And I think it's important to just for this moment touch on alcohol, because sometimes we forget that's a substance too that people may be struggling with, because it is, of course, a socially acceptable substance that people use, publicly. So we like to bring or shine a light on that. And then it goes into signs and symptoms of an alcohol use disorder, which I'm sure that you could take a look at on the website, should you go to that website. And the mention they make is that not all of these symptoms of AUD are obvious to outside observers. Some may not even be apparent to the drinker themselves. It's crucial for anyone consuming alcohol regularly to be completely honest with themselves about their drinking. Recognizing these symptoms early on can make recovery from alcoholism much easier than if one lets them linger and worsen. A comprehensive list of criteria for alcohol use disorder can be read in what's called the DSM-5. While self-diagnosis is not always accurate, individuals should consult a medical professional to consider alcohol rehabilitation if AUD symptoms match their experience with alcohol to a significant degree. And then it does go on to say that many adults do not technically have alcohol use disorder, but still engage in risky alcohol consumption, such as binge drinking. And there's a little bit more information about that, which also includes the following characteristics of binge drinking. You consume more than 4 drinks in a sitting. You sometimes forget what happened when you drank. You've considered cutting back on alcohol consumption. You've felt guilty when you've drank too much. You're not sure how much you drank, and you have been told that you drink too much. With as many as 1 in 8 Americans suffering from AUD, one would hope that the majority of them were undergoing or considering alcohol abuse treatment. So that is just a little bit about one of the things that they treat. And I'm also going to go into a little bit more detail here on substance use, and also they do treat co-occurring disorders, mental health, and dual diagnosis. So the statement here is that the nation's opioid crisis continues to destroy and claim lives as ever-increasing numbers abuse prescription painkillers and other highly addictive substances. Alcohol abuse is widespread, with the rate of alcohol use disorder increasing among certain demographics. Benzodiazepines are commonly abused in what many professionals are referring to as a hidden epidemic. All of these substances present serious health risks to users, including the possibility of overdose, the physical decay wrought by heroin, the cognitive decline of alcoholism, or the severe withdrawal symptoms of benzodiazepine dependence. So today, it is not just an opioid crisis we have in our hands, it's an addiction crisis. While many try to quit on their own and live a life of sobriety, few make it. The only proven effective defense is drug rehab. If you or a loved one has a drug addiction, this is what you should know about drug rehab. And it does go on to talk about many aspects of what is considered part of drug rehab. I'll just state here, and again, I'm quoting directly from their website, so I apologize that this is just reading, but I wanted you to at least get some idea of what Granite Recovery Centers was all about. Kind of an important point, I think. Addiction, or as we refer to it, substance use disorder, may arise due to desperation to control chronic pain, a primary cause of the nation's opioid epidemic. It may come out of an attempt to soothe some unacknowledged emotional pain, trauma, or anxiety. Regardless of the form it takes, substance use disorder has profound consequences for every aspect of one's life, worsening problems rather than addressing them. So that's just a little bit more about what they are considering their focus areas on treatment. In terms of their programs, they provide medical detox, residential programs, partial hospitalization programs, otherwise known as PHP, intensive outpatient programs, otherwise known as IOP, outpatient programs, and they also have alumni programs. They use evidence-based practices as their treatment approach. They also have a medication-assisted treatment program, REST 12-step, and Rally Point recovery. Those are all approaches that Granite uses. So with that, I am not seeing anyone still from Granite Recovery Centers. Team, did you happen to see anyone come in? If someone could just confirm that. I don't see him.
No, I have not seen him enter the waiting room.
All right, thank you. So with that, I'm hoping that Farnum may be ready to present now. Charlotte, can you just give me an update on that? I know they're busy giving another presentation to the city of Manchester right now, so.
Karen, I do have a question if they are not ready yet.
I would say they're not because Charlotte didn't unmute herself. So if you could go ahead, Sam, that would be super helpful.
I don't know, is Aware still on? I guess my question for them is, and really this would apply to any of the treatment providers who want to chime in, but if somebody has a loved one and they're looking for support for their loved one, but their loved one maybe isn't fully in a place of readiness yet, do they provide any support around having that conversation, or kind of, yeah, how to have that conversation with a loved one who maybe is not like, yes, I'm ready to go?
So not in like a formal way, like we don't offer like intervention services per se. What I can tell you is that like I am personally always happy to have that conversation with a family member, just because it's just part of my job, and our admissions team is pretty experienced with that also. So, you know, we're happy to give our like opinion on that and share our experience on it, with the understanding that we're not like licensed interventionists, if that makes sense.
Totally.
It does, thanks.
That was a great question, Sam. And I will say this, sometimes in the treatment field, I can only imagine that someone may have had an emergency, and I'd like to think that Spencer and his team are helping someone as we speak, which would be a great reason for them not to be here for this particular part of the presentation. But of course, we welcome them if they do jump in late. So are there other questions right now? And I apologize to the group for these delays. These are unanticipated delays that we have today. And again, Adam, thanks so much for providing such a comprehensive overview and reaching out to your contacts as well. It's greatly appreciated.
Anything I can do.
Karen, I also wanted to share, I did see another person from Farnum join.
Would that be Alexandra by chance? Alex Hamill, I see you. Are you able to present at this time?
Yes, I can do that. I apologize. Got double booked today.
Oh, it's okay. I know you were with Manchester and delivering
Yes.
another presentation, so we expected you to be a little bit late in the call, and we're so glad that you're here, Alex, and also welcome, Charlotte. Glad that you're here as well. But if you want to go ahead and just roll with your presentation, I know everyone here would appreciate that. Thank you.
Sure. I'm going to try and share. I'm sort of not talented in that department.
Alex, I can share my screen.
Oh, excellent. Charlotte can take over the technology part. So what we thought we would do is do a little bit of an overview of kind of Farnum services, rather than a historical piece, but kind of just do a little bit of, I think that people are really interested in how can you get to Farnum? What are the services that are currently being provided here?
All of that. We love all
of that. All right. And then certainly we'll do a quick overview. And then I think a lot of times people have more pointed questions about, they're really specific to where they're calling from and what their specific needs are. But I'm going to speak a little bit to, I'm actually the director of compliance, and I'm going to speak much more to the residential services. We have Alexandra on the line waiting too. She'll talk about how do you get access services. And then I think Charlotte will probably tell a little bit more about outpatient services. And of course, anything that you might need, we have our admissions phone number here and then our outpatient phone number here. So we can move on. So Farnum Center, actually, I'm going to talk about residential services. And for those callers, for those people participating, we are familiar with ASAM, American Society of Addiction Medicine. We really follow that criteria for admissions into our residential services. which we offer 3.7, which is a medical detox level of care. Can you move the, Charlotte, to the next 3.7 ASAM level of care, which is, it's not a full hospital care, but it is medical monitoring, meaning that we have a physician available 24 hours a day. We have providers available 24 hours a day, and a team of people who work with clients who are coming in who need safe withdrawal from their medication, from the substance they're using, primarily alcohol and benzodiazepines. We do work with clients on a limited withdrawal management protocols, often with people with using some of the opiates that may have some more complicating medical, medical conditions that may need a higher monitoring. But we have nursing care available 24 hours a day. We also have clinical services. All clients will get this full biopsychosocial assessment very quickly, usually 24 to 48 hours upon admission, to say where are they going to go from here. Often clients coming into medical, needing medical withdrawal, may be going to a residential type setting, but they also may be going to an outpatient setting, maybe going to a program with housing, so PHP with housing. So getting an assessment and then in a safe place while they're being medically monitored can be very helpful to be able to transition to what is that next level of care. Being in a medical detox doesn't mean you go on to any kind of residential treatment. It means what is the next best placement for somebody. Some people just need to sort of stop that use, get someplace safe where they can stop the use. General length of stay is usually around 5 days, sometimes a little longer depending on what is needed, but generally 5 days for medical detox. Groups are offered. Clients have the opportunity to actually participate in some recovery support groups. And then there is some clinical treatment that is offered twice during the day for clients as needed. As tolerated, I should say. We also have, and there are 27 beds on that unit. We also have 3.5 ASAM level of care, which is residential treatment. This is treatment for individuals who aren't in acute medical need. They are not in any kind of acute withdrawal. They are stabilized, but they lack resources. They lack probably stable housing. They lack that recovery support. They haven't developed the kinds of skills that will prevent them from returning to use very quickly. So this is a level of care that has a team approach. We have clinicians who, again, will do an assessment to say, what are all your needs? Really looking at sort of that full biopsychosocial. I think people are so familiar with you kind of think of the social determinants of health. Where are you living? What are your recovery supports? How is your mental health? All of those pieces. What is your motivation? So all of those pieces are looked at, have a treatment plan put in place. And then when a lot of those concrete things are identified, working with a case management to be able to put a lot of that in place, appointments, resources to, sober housing possibly, make those connections. Maybe there's a little legal stuff going on, make those connections. So there's a concrete solid plan upon discharge. The length of stay is very, very, can be very, anywhere from, let's say, 10 days to maybe 30 days. This would be traditionally what a lot of people call 28-day treatment. It is not 28-day treatment. It really is care based on the individual need. Often it is maybe 25, 30 days, but it is really based on an individual need. What does an individual need? Be able to put a good solid plan in place for what they will doing following a residential setting. Because what we do know is that residential care is wonderful, but a lot of the recovery and the wellness takes place once an individual leaves here. In addition to this, and one of the things we didn't have on here is we actually have an aftercare program. We have an individual who actually does follow up on all of our clients who complete these programs and follows up within about a week and says, have you made those appointments? Have you been able to follow through? And if not, how can we help you? A lot of people leave with their appointment cards in their hands, and then a week later, they don't know what they did with those. So we do that follow-up piece to make sure that people remain well connected. And then they will follow up again in 30 days, 60 days. And one of the benefits of this has been that sometimes people do need to return to care and they're immediately connected right away. Somebody's actually kind of checking on them that has a little bit of connection with them. We do utilize in our residential care, we're Hazelden and Betty Ford curriculum. We're working on doing a lot more integrated care. Understanding a lot of people have co-occurring disorders, so that's something that we're really moving in a direction to do a lot more care along that line especially in our residential services, and so that there's good follow through once people get ready to transition from a 3.5 level of care into a step down, so to speak, to another level of care. Did you want me to speak about the respite, Charlotte, or is Alexandra going to do that?
And the respite is part of the extended doorway, so she can mention it briefly.
Okay. All righty. Those are the residential levels of care.
Hey, my name's Alexandra. I'm the coordinator for admissions here at Farnum. So I could just kind of go over this a little bit quickly, and you guys are always more than welcome to reach out to us if you have any follow-up questions afterwards as well. So we do have 24/7 admissions capabilities here at Farnum. With that being said, we do try to make sure that we are able to complete screenings within our operating hours of 8 to 5 with clients to get them in and make sure they're meeting for the right level of care, whether it be our medical detox or our inpatient residential. So they're able to do those intakes over the phone, or they can actually come in person. If there are some people that when they're doing it over the phone, they get, a little bit overwhelmed with it and it's better face to face. So we're able to kind of schedule them to come in and meet with us, whether that be at the Lake Ave location or Queen City, just so that we can kind of accommodate what it is that they're looking for. But it is very simple to do over the phone as well. It's about a 20-minute process, and we're able to schedule within 24 hours based on bed availability. So it's really kind of a quick turnover rate for when they call, they screen, and they get brought into us. We are working with most insurances. We do New Hampshire Medicaid, private insurance. We work with VA referrals as well as BDAS funding. We do have after-hour walk-ins. So from that 5 p.m. to 8 a.m., when admissions is not in the office, we still allow for people to come in. So we work with the CMC doorway. So we are part of the extended doorway, where if somebody is still seeking treatment and there's not somebody in the admissions department, we're not going to be turning them away. We're going to bring them in as long as we have the bed open. We're going to get them situated and comfortable for the night. If they need monitoring on detox, we're going to put them over there. If they don't need that monitoring, we're still going to get them situated in a respite bed. And then the admissions team will follow up with them the next morning in order to do that intake and just make sure that we get them into the right programming that they're meeting that care for. We do accept, we take phone calls, obviously, from referral sources as well. And we do have an email address that will be on the screen in the end, that if you have anyone that's interested in coming in and you just have questions or even releases of information you want to get over to us, it's really simple to just get a hold of the team so that we can kind of accommodate in the best way for the client and have that quick kind of introduction in and get them into a bed. I don't know if Charlotte or Alex, you want to add to any of that?
So our outpatient programming is located at 700 Lake Ave in Manchester. Through our outpatient services, as Alexandra mentioned, we do have a portion of our admissions team located over there for clients to be able to, if they prefer to do their intake screening in person, they're able to meet with admissions there. We also have the ability to do open access assessments, and that's for clients to be able to get a full level of care assessment with one of our clinical team to then be able to determine the best avenue for meeting their level of care and their treatment needs. We offer intensive outpatient IOP groups, both in the morning, in person, as well as in the evening via telehealth. As most probably know, IOP is attending a group format 3 hours a day, 3 times a week. Our IOP is divided into 2 phases. The first phase is the 4 weeks of 3 times a week coming and meeting with their group, as well as during that process, meeting with their assigned individual clinician. At the completion of phase 1, depending on their individualized needs, they would then do the continuing care portion, which is the phase 2 portion, which is anywhere from 4 to 8 weeks, depending on what their individual treatment plan is, as well as meeting with their individual clinician. We also offer open enrollment in multiple different outpatient clinical recovery groups, both in person and telehealth. We have afternoon and evening group schedules. We have groups actually every day of the week for particular clients who want to be able to supplement their individual care or their IOP with attending group as well. And as I mentioned, that's open enrollment, so the clients are able, to attend which group best meets their needs, as well as if there's a particular week where they feel they need more support and they're not meeting with their individual clinician, they're able to come in and attend one of those groups. We also are an impaired driver service provider. So we do have the ability to do LADAC evaluations by our licensed clinicians, as well as collaboration with the New Hampshire IDCMPs to facilitate the client service plan requirements. And we do have licensed clinicians who are able to provide individual as well as groups to be able to meet those clients' IDCMP care service plan requirements. And as Alexandra mentioned, this is the best contact information for both our admissions department and our outpatient services.
That's excellent. Thanks to both of you. I would like you, if you wouldn't mind, to send me your slides so I can share those with participants following the presentation, so they will have all that contact information. That would be greatly appreciated. I have one quick question, and then want to make sure nobody else has questions right now. Can you elaborate a bit more on what kinds of support services you provide for family members and loved ones?
So within our outpatient department, we do have one of our groups that we offer in the evenings is for clients and families. We also have a recovery support worker who is offering coordinated care both for our clients and their families if needed, to be able to help connect them with other community resources as well.
Great.
Alex, I don't know if you want to speak on the family component and the visitation piece as far as at Queen City Residential.
Sure. On one evening a week, we do have family visits, which would be for family members with children, meaning small children. They kind of think about, well, if you can't drive, then you are a child, and you can come in with a family member, and somebody could see their toddler or an 8-year-old or something. So we do have that component. So there is a family visit on one night a week. And on the weekends, we do have family visits, and we are offering family education prior to visits. Again, around different aspects of, having a loved one who is, in treatment, and then, different aspects of that. And that is prior to a visit. And additionally, what we have been doing is we offer the client the same information and education as the family members are getting at the same time. So they are both getting the same information, but just separately.
Gotcha.
Which we found works well. That way, it's like, well, they told me this, and it kind of helps with that whole process. Everybody's getting the same information. It's just away from each other.
Sure.
Before the visit.
And apologies if you did mention this, but can you share what insurances you take?
Alexandra would probably speak better to that.
Yeah, we work with New Hampshire Medicaid. We work with most private insurances as well. We take VA referrals. We do have BDAS funding that we're able to utilize. So we do work with a large scope of things. We do get, a hefty amount of New Hampshire Medicaid, because I know unfortunately not everyone is able to accept all those insurances through them, but we can. But again, private insurance, VA referrals, BDAS, we do it all.
All right, thank you so much. I appreciate that. And with that, I'm going to have you stop sharing your screen, and I would like to introduce Spencer Bush-Brown. He's the Vice President of Business Development for Granite Recovery Centers. And Spencer, so glad you could join us this morning. Thank you.
Yes, thank you for having me. I apologize. I'm coming to you from the road today, so I'll be giving my presentation without slides, but I can send you some information this afternoon.
Perfectly fine. Thank you.
All right, awesome. So I'm Spencer, Vice President of Business Development at Granite. I've been with the organization for 7 years now. We've had a lot of growth over that time. As far as the locations across the state we have now, we have Green Mountain up in Effingham, which is a full continuum of care. We offer detox, residential, PHP, IOP up there. A lot of evidence-based treatment involved in what we do, including 12-step programming to kind of give a full, well-rounded course of treatment for individuals who come up to us. Length of stay averages around 45 days through the full continuum. We like to tell people 30 to 60, though, depending on their insurance and coverage and all of that. But really focus on keeping people in treatment as long as we can in order to, get the best outcomes, and recommending, thorough aftercare as well, working with different organizations across New Hampshire as well as New England to help people continue on in their recovery. Up at Green Mountain, we do accept all insurances. We're in network with pretty much all commercial insurance that you would come across in New England, including Aetna, Beacon, Blue Cross, Cigna, Fallon, Harvard Pilgrim, Health Plans, Inc., United Healthcare, United Behavioral Health, Tufts, VA insurance. So similar to Farnum, we can take pretty much all the commercial. In addition, we do take all New Hampshire Medicaid as well. We have 2 programs that specialize with Medicaid clients. One is the Granite House, which is in Derry, New Hampshire. It's a residential program, 44 beds. From there, they can transition down to Salem, where we have PHP IOP with room for up to 100 clients. So full continuum there too, with the ability to do some Medicaid detox as well at Green Mountain for those clients. One other program that we've added recently to our group of programs is Liberty Bay up in Portland, Maine. So people looking to get out of the state of New Hampshire or coming from other states across New England can head up to Portland, where we have a full continuum of care as well. Detox, residential, PHP, IOP, in network with most insurances up there besides Aetna and Cigna. And of course, can't take New Hampshire Medicaid, but most everything else, we are in network with there, including the VA insurance as well. I do have an exciting announcement coming that I want to share today. Our program in Canterbury, New Hampshire, New Freedom, which has been open since 2015. We've just received a residential primary mental health license to operate at that facility. We look to be open within 45 to 60 days and being able to take folks with that primary mental health diagnosis. We are in network with all commercial insurance and Medicaid at that program. So exciting opportunity there. Not many primary residential mental healths around, certainly in the state and even across New England. So let alone in network. So we're very excited about that. We just got approval. We have a little bit of construction to do over the next 30 days, but we'll be set to open this summer with that offering, as the rest of our sites are primary SUD, underlying mental health. This is going to be a new area of behavioral health for us that is much needed across the region. So we're very excited about that, and we'll provide more information with you guys as that comes. It'll start residential. We'll offer PHP and IOP as well. So as well, looking for kind of a longer length of stay at that facility, just like the rest of our programs. I think that's the broad overview. Anyone have any questions?
And folks, you can go right ahead and unmute yourselves if you want, or you can put your questions in chat. Spencer, that is very exciting news about Canterbury. That's awesome.
Yeah, I actually
Definitely.
have one, if I may.
Adam.
Sorry, Spencer, how's it going, sir? Nice to see you.
Good. How are you?
Well, congratulations on adding that level of care. I know, just representing Aware, I'm actually actively trying to refer somebody to a mental health IOP right now and having trouble. So there's definitely a huge need. So that's very exciting for me to hear. My question was regarding the primary mental health designation. Does there need to be underlying SUD, or can this be a pure mental health diagnosis?
Yeah, I mean, because of the nature of what we do already, most of these cases will include SUD. I don't believe that they'll need to, have a diagnosed primary addiction, but certainly the substance abuse will be part of the profile with most of the folks that we see. So it won't be a solely mental health. I think most of the folks coming to us will, be using marijuana or, doing some binge drinking, different things like that, kind of to fit within what we do already in terms of treating both. But where it's, primary addiction, underlying mental health, we're flopping that, flip-flopping that. So yeah, I don't think we'll be seeing too many cases that are just mental health. But we'll have to see as we go forward. I mean, we have the opportunity, I think, too, but I think most of our cases will involve some SUD.
Absolutely. Thank you so much, man.
Yeah.
Great question. Christy, can you end the recording in case anyone has a question they did not want on recording, please?